just like
Yeah.
in all Zooms. Hi, Dr. Allensworth-Davies.
Hello, Daryl.
Hi, thank you for being part of our conference. Can you tell our viewers like what you do and where you do it?
Of course. So I first met Daryl actually when I was still a doctoral student at the Boston University School of Public Health. And now I'm happy to report that I am an associate professor in the School of Health Sciences at Cleveland State University, where I also coordinate our Master's in Public Health program. And of course, my research focus, as Daryl is aware, is on LGBT health disparities with a focus on cancer disparities.
Yeah, and very proud that we met early in your career, and proud that we had any influence on the brilliant outcomes so far, and that will be continuing. You're a tenured professor.
Yes.
So that's very good, and good that people from our community become tenured, because then you could say whatever you want and not fear. Um, Tell me, so you've written a number of articles, done a number of investigations on gay and bisexual men and prostate cancer. I think you've also investigated a bit around transgender women.
Yes.
So let's talk about what patients can do to optimize their care based on what insights you found out. So we sort of have a general understanding that it's, you get somewhat better care when you're out to your doctor and your doctor feels safe to you and the doctor feels comfortable with you, and on and on and on. How does anyone know, how does a patient know whether or not they're in a safe environment with a safe doctor?
Well, I think that's an excellent question. And honestly, it's something I recently went through myself. And so I think it's really important to the extent that you feel comfortable to disclose whether or not you are a gay or in some cases even a bisexual man. Especially if you end up undergoing prostate cancer treatment, the recommendations that you receive and how you respond to that treatment and the sexual concerns might actually be quite different than those of a straight man, for example. And so in my case, I tend to be very open as a gay man. And then I also sort of the added layer of being a gay prostate cancer researcher. And so recently, I'm going to share a little personal story here. I've had an elevated PSA for about 6 months. So this is the blood test that is typically used. It's first level screening for possible prostate cancer. And I went to go meet with a new urologist. And I usually like to just let them know up front, like, where my knowledge is around prostate cancer so they don't freak out. And he was very intimidated by me. I don't know if he was intimidated by my height, because I am 7 feet 2 inches tall, or the fact that I'm a gay man, or the fact that I knew a lot about prostate cancer, but he and I were just not a good fit. I could feel the distance during our clinical encounter. And so if you ever have the feeling that a provider is trying to rush through the encounter with you or isn't answering all of your questions, or you feel that sense of distance, I would highly recommend that you go and find another provider, which is exactly what I did. I had a very negative experience. I knew that for something like this that is so serious and where the second level of testing is invasive, I really wanted a urologist who I felt comfortable with. And so I switched to another urologist, again, was very open with him. And his response to me was, let's work on this together. And that's really what you want. You want a healthcare provider who is willing to be your partner and who's willing to give you good information, answer all the questions you might have, any questions that your husband or partner might have as well, or boyfriend, and who's really comfortable in that role. And so with him, I felt completely comfortable. All my questions were readily answered. We would have conversations about different aspects of the next level of testing, which in my case was to receive a biopsy. And I felt really, really comfortable in that situation. So I think part of it is trusting your gut. And part of it is really paying attention to how your interaction is going with your urologist.
And changing urologists, changing doctors. I mean, there's the history of being the good boy, the good patient with your doctor. In the community, that's well experienced. How do you, like for you and in general, what sort of triggers the move to, where you feel I just have to get another doctor?
Well, for me, it's really important that I feel comfortable as a patient. And so, and honestly, it would be pretty unusual for a provider to do something as obvious, for example, as like a homophobic remark. So in a lot of the work that I do, we talk about microaggressions. And so a provider who's not connecting with you or is uncomfortable about the fact that you're gay or anything else, that often comes through in their mannerisms. And that comes through in things like, how willing they are to engage with you. Again, whether the encounter is feeling rushed, whether or not they're fully answering your questions, or if you're getting very short answers. And so if I were ever in a provider situation where I was experiencing that type of behavior and feeling uncomfortable, that would be my trigger to change providers.
So
And I
you
think,
meant, oh, go on.
and I was gonna say, the other way to think about it is you are the healthcare consumer. And so whether it's your insurance that pays for it, you're still contributing to that. Whether you're paying out of pocket, you are the healthcare consumer. So as the patient, at least in the United States, you get to have that choice. You get to choose providers that you feel comfortable with. And so in my opinion, if you shouldn't hesitate, if you're feeling uncomfortable with a provider, to find a provider who you connect with better and who you feel more comfortable with.
Yeah, I mean, you are the boss. The patient is the boss
Yes,
in all
ideally.
situations. Yeah.
I really view it as a partnership, right? Because you have the patient experience. They're the ones who are directly experiencing the testing, the diagnosis, the treatment. And so that's half of the equation. And of course, the other half of the equation is the medical knowledge, what the doctor has. And so I often think of those two halves coming together as a partnership. And so in order for the doctor to give you, the benefit of his training and knowledge, you also need to be open with him about your experience and your concerns and ask your questions so that between the two of you, you can really put together a treatment plan that works for the patient.
Right. And we'll talk about how the two of you, how the doctor-patient thing plays out in a 5 or 10 minutes or so. But you mentioned microaggressions, and it's on my
Yes.
list of things to talk about. So let's hit on that now. I understand the phrase, you understand the phrase. 99% of our patient population struggles to understand it. What is it? What does it look like? What does it sound like? And how does it feel generally?
It's really, it's a different expression of stigma or discrimination. And so I think most of us, when we think of stigma or discrimination, we think of it as something very obvious, like a homophobic slur or derogatory terms. Microaggressions are different. It's a way of expressing stigma or discrimination almost in a much more passive way. So really through behaviors, through how the clinical encounter is being managed. Again, through how much attention they're paying to you. So let me give you another example. Okay, and this is actually from my prostate cancer study. So I interviewed a prostate cancer survivor in St. Louis who shared with me a clinical encounter that he had with, in this case, his primary care doctor. And he wanted to go in and get a hepatitis B test. And his primary care doctor looked at him and said, "Oh, how long have you been an IV drug user?" And he was completely taken aback. And he's like, "I've never used IV drugs." He's like, another risk population for hepatitis B is sexually active gay men. And that's why I want the hepatitis B test. And from that point in the encounter forward, the entire dynamic changed. It was as if his physician didn't want anything more to do with him as part of that clinical encounter. Very cold, very clinical, giving very short, sometimes often one-word answers to questions. And of course, the patient left feeling super, super uncomfortable, right? And so that's usually a good indicator if you've been experiencing microaggressions or not. So this doctor, like, nothing overt, never used a homophobic slur, but just through his behavior and his mannerisms, created a lot of distance, and the patient felt very uncomfortable. Now, the downside of this for LGBTQ communities is often when a member of our community has that experience, they may not go back. It might be years before they decide to go back and engage with the healthcare system again. And when we're talking about something as serious as prostate cancer, that can be a real problem. Now, in this case, it had a happy ending because the patient in this case recognized that this doctor, for whatever reason, did not was not respecting him as a gay man and did choose to go and find another doctor right away. But that doesn't always happen.
Yeah. So with that in mind, why would anyone want to take the chance of being out to their doctor?
Well, in part because, again, and I guess to keep it specific to prostate cancer, and especially if you have been diagnosed and you're going through the treatment process, as I think your patients likely know, prostate cancer treatment can seriously affect your sexual functioning. So it can affect erectile function, it can affect urinary function. And so as a gay man, I think one of the interesting things that I found in my research work is we were really curious, like how did gay men deal with this loss of sexual function compared to straight men? Because it's central to being male and being masculine, correct? I mean, the whole idea of, being able to have and maintain an erection and keep that over time. And so when that function is lost for straight men, it's devastating. A core part of their identity is gone. And it actually creates a lot of anxiety and a lot of depression around that, especially if it's something that can't be fully corrected. With most of the gay men that I talked to in my research work, however, they were able to accept the fact that they might have more limited or no erectile dysfunction, and were actually much more creative in having their sexual needs met despite the dysfunction. Some even went so far as to opt for implants because that was an aspect that was really important to them. They wanted to have that function no matter what. Others may have shifted their roles in sexual encounters or relied more on touch, more on foreplay, as opposed to penetrative sexual practices.
So the idea, what you seem to be alluding to, the idea of masculinity. How does that play out for men who enjoy sex with men after prostate cancer therapies and treatments?
So I really think it exists on, I think it really exists on a continuum. So I think one of the things that happens commonly in gay communities is I often feel that people get labeled as being, a top or a bottom or versatile, but especially in the gay male community, I really see masculinity as existing on a spectrum. And so on one end of the spectrum, you might have the hypermasculine. So, the men for whom, maybe being a top most of the time is important. Having like the muscular body is important, presenting as very masculine. And then on the other end of the spectrum, you may have men for whom that's not as important. And so they may, have more identify with more feminine characteristics, which doesn't make them any less male. It just makes them a different type of masculinity than the kind that is commonly seen in our culture. And of course, you have those in the middle too. So you have those who, at times may, want more of a feminine, softer presentation. Other times might be more masculine, more aggressive, and may alternate between the two. And so I don't think there's one way to express masculinity. I really think it exists on a continuum, and people can change where they are on that continuum.
Right. And is there anything that gay men can learn from straight men regarding the impact of treatment on male masculine self-esteem, and vice versa? What can straight men learn from gay men, from men
Well,
who enjoy sex with men? Yeah.
I think from straight men, I'll have to think about that question for a second, but let's start with the gay men. What straight men can learn from gay men? Because what we did find in the research that I did, and I think it's continued to be found, is that gay men do tend to be more adaptable, especially following prostate cancer treatment and in view of changes in their sexual function. So that is definitely something that straight men can learn from gay men. So I feel if anyone's going to be more pigeonholed into a traditional sex role, sex position, straight men are gonna be more prone to that. And so to the extent that they can realize, oh wait, there are these other things that I can do that are still sexual and still allow me to express my masculine identity, even though it might not be having an erection or penetrative sex. And I think on the flip side, I think for the gay men, the straight men were really, I think, willing to work through and do whatever it took to figure out, their new way of functioning following prostate cancer treatment. And I think that was true to that. That was more of a mixed bag with the gay men. Some were, some weren't. Some gave up. Some were like, okay, I'll never have an erection again. I give up. Not even gonna like try to have sex. But for the straight men, by and large, they wanted to try to find some way. Like that sexual relationship with their partner was very central to their identity and very important to them. And they were determined to find a way to solve that. And so I think for the gay men who have an adverse outcome and are ready to give up, I think, learning from that resilience and being persistent in finding a way for sex to work is probably a good lesson for them.
Yeah. And you mentioned resilience. All men and women who find themselves in minority positions develop an aspect of resilience in their personality, or they just fail to enjoy life.
Right.
So gay men of a certain age, which is to say the prostate cancer realm, let's call it 40 years old and up, even though we have people in their 30s and one that I know of in their 20s who's genuinely diagnosed with prostate cancer. We're men of a certain age,
Yeah.
and, we're a bunch of old guys. We've experienced impacts on our sense of safety, elevated anxiety, barriers to healthcare or education or love or entry into a movie theater or whatever, safety at a Chick-fil-A or whatever those fast food things are called. Apologies for mispronouncing it to those who love their chicken sandwiches, but the idea of resilience is something that we've sort of self-taught and collectively taught each other for many years before a prostate cancer diagnosis. Is there any benefit to that kind of self-history for gay and bisexual men?
Absolutely. And so I think one thing the research is really showing right now, and especially for people in my generation, so I'll be open, I'm 52 years old. I went to college in the late 1980s during the HIV/AIDS epidemic. And I think especially for sexual minority men, having lived a good part of their lives way before gay marriage, really struggling to come out and be their authentic self, to have their relationships recognized, valued, put on equal footing as straight relationships. All of that has built a certain level of resilience over the course of our lifetime. And that's one of the things that the resilience literature is starting to show. Resilience isn't a switch that you flip. It's something that gets stronger and more developed with experience. And so the more life experience you have as a sexual minority man, chances are the more resilience you have been able to build over that time, which means that later in life, which is when most men are diagnosed with prostate cancer. I mean, there are the exceptions for high risk or family history individuals, but by and large, men tend to get diagnosed, age 45 and over, the vast majority of them. By that point in your life, you've developed a fair amount of resilience. And so that actually prepares you in many ways to be able to better handle the diagnosis and the treatment process, which is stressful not only physically, but also psychologically.
So with that in mind, why do the surveys that you and I and our colleagues put out, the FACT and EPIC and all the others that show that higher, slightly more significant levels of distress around emotional content, more depression, anxiety, et cetera, for gay men rather than heterosexual men? If we're so resilient and so battle trained, through the course of our lives, shouldn't we be shining examples of resilience in the face of prostate cancer?
Well, I think in some ways we are going back to the adaptability. But again, especially if you're undergoing treatment that's going to have a strong impact on your sexual function, that's essential to gay male identity as it is to straight male identity. And in fact, in some ways, you might even argue for gay men, it's more central. So, I mean, gay men, especially at least when I was coming out, it was all about, that's how we would initially connect with other gay men. It would largely be sexually first. And then the romantic and emotional stuff usually came after. And so that might explain part of the distress that is experienced. And then when you combine with that, there's also the factor of aging, right? And aging is really, in a lot of ways, not handled well by the gay community. I often joke that I died when I turned 40. So because I was very much part of like that younger, more mainstream gay community in my 20s and 30s, but then I eventually aged out of that more mainstream community and really just held on to more close friends, if anything, from that time. And actually, the work that I did on my studies supports that. A lot of the men that I interviewed had networks in place with other gay men who were the same age, and they had all come of age together in the mainstream gay community, and then they all aged out of it together, and they sort of formed their own little micro community. One network even went so far as to check in on each other. So these were men in their 50s, 60s, and 70s, and they had a routine of calling each other, checking in on each other, making sure that they got to their doctor's appointments, making sure, someone needed to go grocery shopping, they went grocery shopping. So a lot of times those networks that are formed earlier in life and that we age out of the community with often serve as a replacement for family, and especially for gay men who may be estranged from their families.
Yeah. Let's talk a bit about shared decision making. First, I mean, just like I'll let you just give our audience, just so we're all page level, 15 to 20-second definition. What is shared decision making? What's the whole dilly-dally around it vis-a-vis prostate cancer?
So I think shared decision making really comes in when you start talking about prostate cancer treatment. There's a lot of different prostate cancer treatments. And so in that case, I think it's very, very important to be working with a doctor that you are comfortable with, who can give you the correct and most up-to-date information on, the best treatment options. And so it's really, it's going back to the patient working in partnership with their doctor. And so we know from science that some treatment approaches are going to be more effective than others. And some treatment approaches, depending on when your cancer is diagnosed. So for example, the treatment that would be recommended for earlier stages of prostate cancer might be different if you were in a later stage. And so really getting all of that information from your doctor in terms that you can understand, which is really important, because, as a researcher and having this conversation with you now, like I'm trying to keep myself on the lay language page. And I think most doctors do a pretty good job of this, but once in a while they might go into medical jargon. And so as a patient, if it's a medical jargon that you're not understanding, really make sure that you're clear on what that is. Also be really clear on what the risks are of some of these different treatments and procedures. And so only in that way can the patient really choose what they feel is going to be the best treatment approach for them. And ultimately, it should be the patient's choice, not the doctor's choice. The doctor is there to present the options, the risks, they can share what they would recommend, but ultimately the patient has the final decision around the kind of treatment that they receive.
So based on what you're saying, it seems essential that all patients are out to their doctors to whatever degree they are who they are. Is that fair to say?
I would agree with that. I mean, if you're really going to have a transparent and open and the most comfortable possible relationship with your doctor, from my perspective, I've always been out. Like since I was 19 years old, I've always been out to my doctors. And I can say most of the time that's paid off. And I've been able to have a great relationship with that provider. Once in a while, it doesn't. And again, you just need to pay attention to how you're feeling and how that interaction is going to decide if about another provider might be a better fit for you.
Yeah, and I'm mispronouncing it. The corollary, thank you, is that doctors who are, for reasons that we'll just presume are innocent, reflect a homophobia to some degree, they simply should not be involved in shared decision-making or prostate cancer treatment. Is that sort of an interesting idea?
Ideally. And so what's really interesting to me um, is that, and it's not always malicious, okay? And so it's not always the provider being like, oh, I don't like gay men. In fact, most often that's not the case. But what I find really interesting is that when you start talking about sex and gender specific cancers, like prostate cancer, it is much easier for them to make assumptions about their patients. And so I'll never forget a conversation I had with an oncologist who, only saw men with prostate cancer. And I asked the oncologist, so how many male patients do you see that are gay? And I got this completely blank look. And they're like, what? And then they even went so far as to say, I don't have any gay patients. And I'm like, really? Really? Like, just based on statistics alone, you probably have at least one, and you just don't know about them. Like, and so that's the kind of thing we need to keep in mind, and especially in the sex-specific cancers, where there's this global assumption that all men are straight and heterosexual. I think that's where there's an opportunity for education, for them to realize, yes, you're also treating gay men, you're also treating bisexual men, you may also be treating transgender women, actually. And it's important to know how to interact and be culturally competent with those communities. And so the other piece of my work for that reason actually focuses on that. I actually do trainings with healthcare providers to help them understand how to better interact with LGBT patients.
Yeah, and we'll get into transgender women in just a moment, but I do want to ask, I mean, there seems to be this sort of trend or movement in designing urologic waiting rooms that are, predominantly prostate cancer patients or the
Hmm,
occasional testicular patient as like man caves. That's the phrase they
really?
use.
I haven't heard this.
So picture, if you will, picture this, and maybe some of the people in the audience have experienced this. There's certainly one major one here in New York City, where at a major hospital with a major urologist, where they're I don't know whether they're genuine leather, but they're black leather-ish or leatherette chairs. Well, picture a 1950s sort of stereotype of a basement manly room with a big screen TV, although I guess in the 50s they wouldn't have had a big screen TV, and you're surrounded by sports memorabilia. So you have footballs that are signed by whoever, and shirts and uniforms in glass frame displays, and just like a keg
Wow.
section. Yeah, I mean, it's the one that I know of is relatively, maybe about 300 or 400 square feet, but it's really like brutally, like, if you had to make just have this bizarre fantasy, that's what it is. And
Wow.
somebody undoubtedly had that fantasy and paid a couple of million to put it together. What do you think that it tells a gay man walking into that office?
Run for most gay men, not all. I do know some gay men who would appreciate that. Who'd be like,
Yeah,
oh, sports,
yeah, yeah.
oh, leather. Like,
Well,
me,
leather would
no.
be sure, but yeah, yeah,
Speaking for myself, I walk into a waiting room like that, I'm turning around and walking back out and finding another provider.
yeah.
Um, because that does not, for me as a gay man, that does not feel like a welcoming space. And that's the other thing that I always stress when I'm doing trainings with providers. Signaling is so important. And so, for example, I had a primary care doctor here in Cleveland. As soon as you were at the door for their waiting area, they had a rainbow flag decal and another one with all the gender symbols on it. So me as a patient walking into that environment, before I even set foot in there, I can see, okay, this is a safe space for me as a gay man. Like, these are providers who know about, the LGBTQ community. Now, that is not what that waiting room would have said to me, unless they happen to have a rainbow flag up there with the footballs or something. And then I might be like,
No, they don't. And I don't think there's plans for future waiting rooms to have rainbow flags. But the idea that, and even for straight people, for heterosexual people, I mean, that kind of room represents all the bullies they ever met, you know,
That's true,
you know,
actually. It's
and
making a lot of assumptions about men.
yeah, and the corollary, pronounced correctly, for that is if you see like a rainbow flag decal on a door for a heterosexual man, I mean, it may be technically irrelevant, but it sort of says, okay, this office, this practice is open to talking about anything. I
Hmm.
could talk about my weird thing. Did too many masturbation episodes cause my prostate cancer? I
Hmm.
feel comfortable. It seems a no-brainer for doctors to spend 50 cents on a decal on a door,
Yes,
which opens up a conversation that leads to better treatment. I mean, imagine a 50-cent intervention that helps men live longer and happier lives and helps women,
exactly.
and everyone. It's extraordinary that more people don't do this. Let's spend the last 5 or 10 minutes or so talking about your insights around transgender women.
Okay, so first of all, I just want to say that of all of the parts of the acronym of the LGBTQ community and cancer, the transgender community is, to me, the one that I think represents a community that really needs to be taken seriously for a high level of intervention. And here's why. So as a transgender individual is transitioning in whatever way they are doing that, it is not unusual for them to reject the part of their anatomy that is no longer part of their new gender identity. So as an example, a transgender woman, even though she may still have a prostate, it may not occur to her to have prostate screening done. And in fact, she may be very resistant to it because that part of her anatomy no longer fits in with her new gender identity. And so what's happening as a result of this among transgender individuals, and when you add into the fact that most transgender individuals have limited to no health insurance, most of them are working in lower paying jobs, most of them are lucky to just be surviving in many cases financially. And so there's all these barriers already for them coming into the healthcare system. And so then if they do think there's something seriously wrong and they make it into the healthcare system, often they're going to be diagnosed at later stages of sex-specific cancers, whether it's prostate cancer or breast cancer in the case of transgender men. And honestly, our healthcare systems still have a long way to go in working with transgender patients. I attended a national meeting in Chicago a few years ago, and they had a panel of healthcare providers and advocates for the transgender community. And I will never forget, one of the advocates stood up and said, when you're a transgender person, you never think about where you can get the best care. All you think about is where you can go where it's not going to be a complete horror show. And so between the access barriers and the potential for stigma and discrimination, um, I think that receiving prostate cancer care as a transgender woman is very, very challenging, and often more challenging than it would be for anyone else. And so in those cases, to the extent, one of the things I think the transgender community has done well, at least I know they've done a pretty good job of it here in Ohio, is they really have set up these internal referral networks. And so no one goes blind into a doctor's office. Like transgender community members, like they share where they've had the good experiences, they share where they've had the bad experiences. And I can say, at least in the Cleveland area, major medical systems like Cleveland Clinic really are making efforts to provide better care to their transgender and non-binary patients, but they still have a good ways to go.
Yeah. Have you had any opportunities to interview any transgender women who are diagnosed with prostate cancer?
I have not, and I would love to, honestly.
Mhm.
And so in the book chapter, as you know, like, okay, Daryl and I were part of a textbook, and in the chapter that we published, I have a colleague of mine here in Cleveland who's done a lot of work with transgender individuals. And so most of the evidence that I have is very anecdotal. It's from, cases or maybe people that I've met briefly at conferences or in other venues, but I've not had an opportunity and actually to do an interview with a transgender prostate cancer survivor. And honestly, that would be a great person to have for you, Daryl, as part of this series that you're doing.
Yes, and we have a transgender woman who's will be speaking, and
Oh, wonderful. That's great.
yeah, and we'll see who else shows up on our schedule. But we do have some doctors invited who have treated transgender women with
That's
prostate
great.
cancer. And in my practice, I'm up to 14, so
That's
it's
wonderful.
yeah. So my insights I may just do a brief talk from my work with transgender women. Um, Thank you so much for this talk. I think it's
Oh, you're
enlightened a number
welcome.
of people and validated a number of concerns that others have had. So grateful for that. Did you want to share any more news about your health, or you want to keep that?
Oh, about my health. Well, I'm
Yeah.
happy to report that I did have a prostate cancer biopsy done. And so of course I'm a researcher, right? And I've been on the researcher end of this, but not the patient end of this. So part of me was really fascinated by the whole biopsy process. And it's funny because I was talking to my urologist about, I'm like, wow, this is really fascinating. Oh, so this is what you do. Oh, okay. Like, because I never knew all the details behind it. And so to actually go through it was kind of, I don't know, in some ways it was validating because I'd read about so many other people's experiences, and here I finally had my own. I'm happy to report my biopsy was negative. So just to let people know. But no, it's for me, anytime I have an opportunity to go from being the researcher to the patient to more fully understand that experience, I love that. I love
Yeah.
that because it really does help me deepen my understanding then.
Good. You're an example for all investigators, researchers, and academics to both experience what they're looking at as well as be sensitive to the people they're talking to. Thank you so much.
You're
Good
welcome.
that we co-write things every now and then, and I
Yes,
hope there'll be more opportunities. Okay,
absolutely.
and welcome to our faculty. You're now on
Thank you.
Mailcare's faculty too. Okay,
Oh, great, thanks.
sure. Okay, bye.
I